Greetings to all of you, my dear students. It's been since a long time that this topic has been pending, so I could not get time to record the topic, even though I have prepared the PPT. So we will finish it now. The topic is opioid analgesics and antagonists. So before going into the discussion proper, that is opioid analgesics and antagonists, we'll see what is pain and what are various types of pain before getting into the discussion proper. Pain is an unpleasant sensory and emotional experience associated with potential tissue damage. So whenever there is tissue damage, the patient will feel the pain, and it is a subjective experience which cannot be objectively defined or quantified satisfactorily. That means I can't know how much pain you feel, and you can't know how much pain I feel. So it has two components, that is a specific sensation of pain and also the emotional reaction to pain, that is a suffering. So why we are discussing about this point, that is like pain and then emotional reaction to the pain. So it depends upon the management of pain. So that will come across in the subsequent slides. So it is a warning symptom, though protective. So otherwise it is damaging. Then pain receptors are distributed throughout the body. That we'll discuss later. Then analgesia, what is it? Analgesia means pain sensation. It is an unpleasant bodily sensation perceived as suffering, usually evoked by an external or internal noxious stimulus because of maybe bodily damage of the internal organs. And analgesics are the drugs which possess significant pain relieving properties by acting in the CNS or on peripheral pain receptors without significantly affecting consciousness. So these analgesics are the drugs which can either act through central nervous system or even peripheral pathways. That we'll see which drugs act through CNS and which drugs act through both CNS and peripheral pathways. Opioid analgesics exert their therapeutic effects by mimicking the actions of these endogenous opioid peptides and these receptors. So we'll come across that what is endogenous opioids and what are exogenous opioid analgesics that we administer from outside. And these opioid analgesics act primarily at the level of spinal cord and brain, while NSAIDs act primarily at peripheral sites to inhibit the synthesis of prostaglandins, that are the pain sensitizing substances. So this is the main difference between opioid analgesics and NSAIDs. NSAIDs is purely peripheral action, and here it is central action as well. So then coming to the various types of pain. So clinical classification of pain. Superficial or cutaneous pain, deep non-visceral pain from muscles, joints, ligaments, and bones, visceral pain, referred pain, differentiation or neuropathic pain, psychogenic or functional pain. So somatic and visceral pain. What is the main difference between these two? Somatic pain means superficial, that is from skin or subcutaneous tissue. And visceral pain means from the viscera, internal organs, that is, it could be like from the heart, it is angina pectoris, and from the gut, that is peptic ulcers, and then intestinal colic, renal colic, etc. So this somatic pain, again, is it can be even deep also. So one is superficial from the skin and subcutaneous tissue, and deep somatic pain could be not from the viscera, but from the muscles, bone, internal structures, that is not the internal visceral organs, but internal in-depth structures, that is muscles, bones, fascia, periosteum, etc. So that can give rise to pain originating from fractures, arthritis, fibrositis, rupture of muscle, belly, etc. So the somatic pain is the pain arising from skin and from the deep non-visceral structures like muscles, bones, and joints. It is usually well defined, so the patient will be able to describe it properly and clearly. And inflammatory reaction in the tissues accompanied by contraction of the surrounding skeletal muscles giving rise to rheumatoid arthritis also comes under the somatic pain. And other examples of somatic pain are direct irritation of a nerve in case of trigeminal neuralgia or herpes zoster, and increased pulsation of the intracranial arteries in case of migraine, and vascular insufficiency giving rise to pain in case of TAO, And then pain arising from the skin and superficial mucous membrane or nerves. So that can be experienced like pricking if it is brief, and stinging or smarting or burning if it is prolonged. So why we are discussing about this? Pain is like whether it is pricking or brief or prolonged, or how it could be like stinging, smarting or burning type of pain. when you come across a case, so as soon as the patient comes, if the patient is suffering from pain, just by taking the history, detailed history, half of the diagnosis, that is a professional diagnosis, half of it can be completed. So just by depending upon like how the pain, you have to ask the patient in the history. So whether it is like a brief, whether it is like pricking type or burning type. So based on that, the patient cannot explain whether it is the deep pain or superficial pain or short duration pain or long duration pain. So you need to identify that. So this type of pain arises from integumental structures or from connective tissues, that is because of either inflammation, that is giving rise to headache, myalgia, toothache, pain of various types of arthritis. And this can be treated with NSAIDs like aspirin. Then deep non-visceral pain, which has a dull character, accompanied by a sickening sensation due to an autonomic response. And it could be referring to the other areas of the body. Then BP and pulse are not much affected unless the pain is acute and severe. So routinely it is not affected. Then what is the visceral pain? We can see. So this is all the internal visceral organs are getting affected, like liver, gallbladder, small intestine, all these things, internal organs. Here you can see this referred pain. I'll show it to you in the other diagram. So we'll go to that. Then visceral pain. So diffuse, less easily localized, and often referred. So it is diffuse because internal organs which are located deep within the body are getting affected, whether because of inflammation or infection, whatever it may be. So diffuse, less easily localized. You can't just pinpoint exactly where the pain is. Dull aching or colic in character, accompanied by sweating, nausea, fall in BP, and even shock. So BP is not getting much affected in case of the non-deep visceral, non-deep pain. That is like what we can say here, this deep non-visceral pain. So then here, the muscle rigidity and hyperesthesia are most commonly associated with this because of the visceral pain. And it could be due to various examples, that is spasm in case of renal or biliary colic, and ischemia, that is myocardial infarction, due to inflammation, that is appendicitis or pancreatitis, and due to stimulation of the sensory nerve endings, that is because of peptic ulcer. Then it is the pain arising from visceral structure and is severe type. So that's what we have just now discussed. MI pain, postoperative pain, severe burns, pain due to fracture of long bones, cancer pain, pulmonary embolism, all these acute conditions. Drug of choice is opioid like morphine. So there it was NSAIDs like aspirin, and here it is opioid like morphine. So what are the gross differences between somatic and visceral pain? Let us see. Somatic pain can be superficial, that is arising from skin or muscle, or deep, that is like non-visceral pain, that is could be from joints, tendons, and bones. And here the visceral pain from the hollow internal organs and the smooth muscle nociceptors that are sensitive to stretching and hypoxia and inflammation, they also can give rise to the pain. Then here the nociceptors are involved, and it is often well localized. Here it is not that localized, and usually described as throbbing or aching in case of somatic pain. And here it is most commonly associated with pallor, sweating, blood pressure, and heart rate changes. So that is the main difference between somatic and visceral pain. Then coming to the referred pain, it is the deep pain, whether visceral or somatic origin. So deep non-visceral pain and deep visceral pain are there. So whether it is visceral or somatic in origin, it is a deep pain, may be misinterpreted as coming from some part of the body other than the actual site of stimulation, that is called referred pain. So actual organ that is getting affected is something, and the pain where the patient is feeling is something distant from the organ which is actually getting involved. So for example, cardiac pain. So the patient is having chest pain. So commonly referred to the left arm, and then the diaphragmatic pain to the left shoulder. So that is the referred pain. So heart is involved here and radiating, that is referred pain is to the left arm. Diaphragm is involved here, and then it is radiating or referring to the left shoulder. Then usually the pain is referred to a cutaneous area. So why? What is the reason behind this? So actual organ that is involved is different, and the pain where the referred pain is felt at somewhere place. So the reason is the both areas have the same cutaneous nerve supply. So the same spinal segment from which the nerve supply both the areas are getting is the same. So here you can see, this is what I was telling. So this is heart. So chest pain, MI pain, or anginal pain. So the patient will be complaining of referred pain to radiating to the left arm. So just one example I'm just giving you. So the things you can go. Then differentiation pain, it could be because of partial damage to axons and nerve membranes, which become very sensitive to mechanical or chemical stimuli. So any sort of injuries. Then it could be burning, superficial or disastric type, and then of stabbing or lancinating character. So it has a peculiarly unpleasant quality about it. So it is not responding to either opioids or NSAIDs. First, the somatic pain with NSAIDs, then visceral pain with opioids, but differentiation pain is not responding to anything. Then psychogenic or functional pain. So it is a vague pain which follows no definite anatomical pattern of distribution. So throughout the day, patient suffers from the pain. So, but the patient will be does not disturb the sleep. So he may be able to sleep. It involves more than one part of the body. If you ask the patient where actually exactly the pain is there in the body, so the patient will not be able to localize the pain. So he will tell here, and then again, if you ask second time, then here, then here, then here, like that. It is because the organic defect is not there, organic damage is not there, but it's just like psychogenic or functional pain. So because of which the patient is not able to localize the pain. Then psychogenic pain is often preceded by a phase of exhaustion, whereas organic pain brings about exhaustion. And here, the predominant element is psychogenic element that is present in all types of functional pain. So now we know what is analgesia and what are the various types of pain. So when a patient walks into your chamber, when you open a clinic as a clinician, so then when the patient walks on, our professors used to ask just before the patient lands enters into your room, at least a quarter of the diagnosis should be done just by observing the gait, then how he walks, then how he's expressing, everything like that. And if it is like hidden agenda, like hidden areas are getting involved, then by extracting some amount of diagnosis, by extracting the detailed history, and some amount of diagnosis by physical examination has to be done. So this is over. Now you know all various types of pain. So if you know, you might be thinking that why opioid analgesics means directly, why can't we go directly into the topic? So we have opioid analgesics and non-steroidal anti-inflammatory drugs. The topic is already over for you. That is NSAIDs. So both are painkillers. Unless and until you know various types of pain, you will not be able to pick up which group of drugs you have to choose for the patient, whether it is NSAIDs or opioids. So for that, you should know the background of the various types of pain and the pathology behind it. So now we know the various types of pain. Now, I would like to put a question in front of you. Why an emotionally charged soldier feels no pain even when he sustains severe injuries in the battlefield? So just would like to give one small pass. So just try to think about it. So pain everybody feels. So what is the reason, at least for some period of time, the pain, like a soldier is not able to feel the pain? So that means there is something is there in the body which is acting like analgesic, nullifying the pain sensation. Let us see what is it. Endogenous opioid peptides. Endogenous within the body, opioid peptides, just like the opioid molecules. So they refer to naturally present endogenous substances which act on opioid receptors. Just like that of the opioid molecules or opioid drugs, we have endogenous opioid peptides within the body, which also act through opioid receptors and produce analgesia. So a number of endogenous opioid peptides having morphine-like actions were isolated from brain, pituitary, spinal cord, and GIT. And they are nothing but we have three distinct families, that is endorphins, enkephalins, and dynorphins. So all of them, these three groups of endogenous opioid peptides, they share a common terminal amino acid sequence which contains 5 amino acids, which can be referred to as opioid peptide feature. Then these three classes of endogenous opioid peptides are derived from its precursor polypeptides, that is pro-opiomelanocortin, that is POMC, and pre-pro-enkephalin or pro-enkephalin A and pre-pro-dynorphin respectively. So POMC gives rise to endorphin, pre-pro-enkephalin gives rise to enkephalin, and pre-pro-dynorphin gives rise to endomorphin. So this is how the precursor polypeptides gives rise to these three classes of endogenous opioid peptides. So they are released during stressful conditions like pain. So whenever the patient feels pain, immediately within the body, endogenously, these opioid peptides are released. And they serve as natural pain modulators. So up to a certain extent, the pain can be nullified just by the release of endogenous opioid peptides. Then, naturally, milk and milk products contain opioid peptides, that is beta-casomorphins, which are released from casein in the intestine. So as soon as the patient ingests the milk, that will be beta-casomorphins will be released by the digestion of casein in the intestines. So which may modulate GA function, so which can act like that of the endogenous opioid peptides. So this is for a point of notification. Then in addition, there are endogenous opioid related peptides, that is orphanin FQ. There are endogenous opioid related peptides, that is orphanin FQ or nociceptin, and then endorphin 1 and endorphin 2 are also available from the other three classical endogenous opioid peptides. Then we do have synthetic opioid peptides like DAMGO and DPDP and morphiseptin. You can just try to remember this morphiseptin molecule, that is enough. So here, endorphin from POMC, then it also gives rise to the ligands, that is like the beta endorphin, MSH, ACTH, and LPH. Then enkephalins from pre-pro-enkephalin, so it has lu-enkephalin and met-enkephalin. Dynorphin from pre-pro-dynorphin, so which has dynorphin A and B molecules. So you can see here, so the peptides are met-enkephalin, lu-enkephalin. Then here, melanocyte stimulating hormone, adrenocorticotropic hormone, lipoprotein, and endorphin. And here, alpha and beta neoendorphins. So the precursor molecules that we have already discussed about. Since these are MSH, ACTH, and lipoproteins are non-opioid peptides. So apart from opioid peptides, non-opioid peptides are also found here. So now we'll see these endogenous opioids acting through opioid receptors. We have mu1 and mu2 receptors, delta receptors, and kappa receptors most commonly involved, giving rise to various sorts of effects. That is euphoria, mu1 receptor mediated action with endomorphins, giving rise to euphoria, supraspinal analgesia, confusion, dizziness, nausea, low addiction potential. And dynorphins and beta endorphins, they can give rise to respiratory depression, CVS and GI effects, meiosis, urinary retention through mu2 receptors, and then enkephalins by acting through delta receptors, they give rise to the effects like spinal analgesia, opioid reinforcement, CVS depression, decreased brain and myocardial oxygen demand, and dynorphins through kappa receptors, supraspinal and spinal and peripheral analgesia, then dysphoria. Here it is, all these cases it is euphoria, but with kappa receptors it is dysphoria, and then psychotomimetic effects, and then feedback inhibition of endorphin system. So this is predominant, that is quite peculiar, kappa receptors. So please try to remember that point. So what is this? The nociceptin opioid peptide. It is also called as orphanin FQ. So we have three. So all three were discussed just now. And then the fourth endogenous opioid peptide, that is nociceptive opioid peptide, NOP. So otherwise known as orphanin FQ. So it was derived from the precursor proorphanin. It is orphanin and the derived from precursor that is proorphanin, that is found in hippocampus, cortex, and many sensory neurons. So this nociceptive opioid peptide, NOP receptor, modulates drug reward, reinforcement, learning, and memory process, also implicated in learning, memory, and then cough reflex and Parkinson's disease. So why it is named as nociceptive? Because it paradoxically causes hyperalgesia. So all the three are producing analgesia, whereas the fourth molecule, it is producing hyperalgesia paradoxically when injected into brain. So an effect opposite to the other three endogenous opioid peptide mediated actions. So this nociceptive or orphanin FQ precursor also provides another peptide called nocistatin. So we have another molecule, fifth molecule, that is nocistatin. So which has pharmacological effects opposite to that of the nociceptive. Okay. Then, so we know types of pain, endogenous opioid peptides, including the nociceptive. Then we will come across the few terminology words that we come across throughout the session. Opium is a Greek word meaning juice or the exudate from the poppy. And opioid, that is all the synthetic derivative compounds related with opium. So they act like that of opium. Opioid, similar. Opiate means drugs derived from opium. So they are derived from opium. Opiate, morphine, codeine, thepain, and papaverine, etc. Then narcotic, a drug which produces drowsiness or sleep. Then allodynia means pain due to a stimulus that usually does not cause pain. Generally, that stimulus will not cause pain, but it sometimes causes pain, that is allodynia. Then analgesia means increased sensitivity. Hyperalgesia means excessive increase in sensitivity to pain. Paresthesia means abnormal sensation, that is feelings of pins and needles pricking kind of sensation. Sometimes in the feet, the patient complains of, or even the hands, the patient complains of. Dysesthesia, that is painful paresthesia, burning foot in diabetic neuropathy. So that is the difference. Then narcotic analgesics. So we have like opioid analgesics, which were also referred to as narcotic analgesics. Now we are not using that term right now. So these were once upon a time used, referred to as narcotic analgesics. Now why we are not using this terminology is because they do not cause, some drugs, they do not cause narcosis, while many drugs which cause narcosis, they are not analgesic. So this term is not appropriate for the opioid analgesic. So now we are not using this terminology. Like for example, barbiturates, ethanol, and some general anesthetics, they do produce analgesia, but they are not analgesic. So they cannot be called as narcotic analgesics. Then the term narcotics is reserved only for legal aspects and covers only those drugs whose manufacture, distribution, and prescribing comes under Narcotic Drugs Act. Then coming to the history and source. Opium. So you're seeing the plant. Hope you must have seen somewhere outside. So sometimes when you come across a case of poisoning, so the patient attendants, they bring out the plant which the patient has consumed. So that's why whenever I discuss about any toxicological aspects of medicine, so I just try to put the diagram of the plant. So you should know which plant it is. And in your mother tongue, in Telugu, what it is called as. So from that plant, which part of the plant is going to give rise to which sort of toxic compound. So this much knowledge, at least you have to have to deal with the toxicological cases in acute medical care. So opium, it is a dried latex, latex obtained from the plant Papaver somnifera. So I'm leaving it to you what it is referred to as in Telugu. Okay, so refer in the dictionary. Then the opium poppy is the source of crude opium, that poppy capsule, from which morphine is opium alkaloids or morphine is extracted. Sir Turner in 1805 isolated morphine, the pure alkaloid, naming it after Morpheus, the Greek god of dreams. So it is the Morpheus, Greek god of dreams. You seeing the picture? Then, so he is the Sir Turner. Then Afghanistan, Pakistan, Thailand, these are the areas where these geographical areas where these plants are grown in excess. So we extract the alkaloids, opium alkaloids from this plant, that is morphine, codeine, papaverine, tabane, so many, etc. Around 20 alkaloids are extracted. So this is the point that is extracted from the our main source of our pharmacological book, that is the Goodman-Gilman. Among the remedies which it has pleased Almighty God to give to man to relieve his sufferings, none is so universal and so efficacious as opium. So why this point is so efficacious opium? Opium also have so many dreadful toxic manifestations. But still, why it is called as so efficacious? For example, if you enter into the cancer ward, then you will appreciate this sentence much more better. That means when a patient is suffering from chronic cancer pain at the last stages of the disease, then the only result that the patient can get relief means it is like not complete relief, but at least little sort of relief can be experienced by the patient just by using only opioid analgesics. That is God's gift. Then poppy seeds. The poppy seeds are devoid of pharmacological activity. Are you able to see this here in the picture? So they are used in food preparations in early days, not now, most commonly by Chinese. Then poppy capsule. So this is the capsule. So the unripe seed of the seed capsules of the poppy plant are incised and the milky exudate. So this is like exposed to the air, and then it can be collected also and then dried. So this browny gummish mass results on exposure to the air. So this contains crude opium, from which around 20 types of opium alkaloids are derived, including morphine. So this is the crude extract of opium alkaloids. See, this is extracted, milky extract is extracted and then dried. This is crude opium. This is the seeds of the opium poppy. Then what are these opium alkaloids? So opium contains more than 20 alkaloids. So they are again subdivided into two types, that is phenanthrene group and benzyl isophenylene group. So phenanthrene group contains 8 to 20% of morphine, 0.5 to 2.5% of codeine, and 0.2 to 0.4% of tabane, that is convulsant toxic drug. Morphine and codeine are both type opioid analgesics, while tabane is not. Tabane is convulsant toxic drug. Then benzyl isophenylene group of alkaloids, they do have papaverine and noscapine. Noscapine is a cough suppressant, whereas papaverine has directly acting smooth muscle relaxant property, which is used as either vasodilator or to treat erectile dysfunction. And morphine is about 10% of crude opium. So in that crude opium, which contains more than 20 types of alkaloids, so morphine constitutes only just 10%. But morphine is unique since it also alters the emotional reaction to pain. We discussed it in the initial slides. So emotional reaction to the pain and the pain itself. So these opioid alkaloids not only alleviate the pain, but also take care of the emotional reaction to the pain. So the patient feels, even though the pain, some amount of pain is there, when it is not completely abolished, the patient feels comfortable. So that is given by only opioid analgesics, but not by non-steroidal anti-inflammatory drugs. That is the main point of interest. And even when the patient is not patient, I cannot use the word patient, even if a person is not having any pain, if he takes opioid derivatives, then also he feels like a good sense of well-being, because of which these compounds are mostly used as drugs of abuse. Then analgesics, a drug that selectively relieves pain by acting in the CNS or peripheral pain mechanisms without changing the consciousness, but it does not remove the cause. That is analgesic. Then classification of analgesics. So how many types of analgesics are there? Let us see. Number one is opioid or narcotic or morphine-like analgesics. So they relieve pain along with producing drowsiness, sleep, or stupor. Example, morphine. Non-opioid or non-narcotic or non-steroidal anti-inflammatory analgesic antipyretic agents. They relieve pain, but they do not disturb uh, state of consciousness. That is like they do not produce any sedation or drowsiness. So this is two groups. And apart from that, we do have analgesic adjuvants also. So here, what is this analgesic adjuvants? Pain generally is associated with other components such as anxiety, depression, and fear, etc. So there are certain compounds, chemical molecules, which are not, they are not going to produce exact analgesia, but uh, they alleviate the pain by producing some other action like antidepressants, like amitriptyline, anxiolytics, anticonvulsants like gabapentin, pregabalin, carbamazepine, lamotrigine. They are not referred to as analgesics, but because of their central nervous system inhibitory action, they do produce analgesic kind of effect. So they are referred to as analgesic adjuvants. These drugs were formerly opioid analgesics, narcotic analgesics. That point we have already discussed, so better leave it now. Then opioid analgesics. So that is a broad classification of analgesics. Then again, opioid analgesics are again classified into subcategories. Number one is agonist. That is morphine and its derivatives, codeine and its derivatives, synthetic compounds like pethidine, methadone, propoxyphene, levorphanol, and tramadol. These are all agonists, opioid receptor agonists. So you know what is agonist, what is antagonist, all these things. Then antagonist, that is naloxone, naltrexone, and nalmefene. Then partial agonists, so they're not fully up to the level of the agonist. So partial actions like agonists. So they have partial agonist action only on mu receptors, example buprenorphine and meprazinol. And then mixed agonist and antagonistic action. So agonist at one type of opioid receptors and antagonistic action at another type of receptors. That is nalbuphine, pentazocine, and butorphanol. So here the point of clinical importance is patients who have received repeated doses of morphine or morphine-like drug for a long period of time for chronic cancer therapy or whatever it may be, for drug abuse, whatever it may be. So when you are like, the patient will be landing upon into a state of physical dependence. So when you withdraw it, it may produce withdrawal reactions in the body, especially when given a mixed agonist and antagonist. So opioid and non-opioid analgesics, we know. Then adjuvant analgesics like anticonvulsants, antidepressants, local anesthetics, corticosteroids, alpha-2 agonists, NMDA receptor agonists, topicals, and then miscellaneous drugs. Then classification of opioid analgesics again, agonists, partial agonists, and antagonists, and mixed agonist and antagonist. So here agonists, antagonists, mixed agonist antagonist, and partial agonists. So these are the various subclassification of the opioid analgesics. So then natural narcotics, morphine, codeine, thymine, semi-synthetic heroin, oxycodone, hydromorphone, and ethorphine. And then synthetic, purely synthetic molecules, that is pentazocine, meperidine, fentanyl, methadone, propoxyphene, etc. And of course, endogenous opioids. In the beginning itself, we have discussed about it. Then how do these molecules, whether it is purely synthetic or semi-synthetic or natural compounds, or even endogenous opioid peptides, how do they act? That is through opioid receptors. So let us get into the details of those opioid receptors. So they do produce both central analgesia and peripheral analgesia as well. So we'll discuss about it step by step. Central analgesia. So we have so many types of opioid receptors. Number one is mu opioid receptors, subclassified into mu 1, 2, 3. Delta opioid receptors, subclassified into 1 and 2. Kappa opioid receptors, kappa 1, 2, 3. So don't need to go into the details. So here 3, and here 2. Then nociceptive. Okay. So we have mu, delta, kappa, and nociceptive or orphanil FQ. So this point we have discussed already regarding the endogenous opioid peptides and then acting through various opioid receptor subtypes producing various sorts of effects. So little bit more clear in this tabular column. Mu receptors, kappa receptors, delta receptors. Analgesia. Here kappa 1 receptors analgesia. Here it is spinal analgesia through M2, supraspinal through M1. So analgesia spinal plus affective component of supraspinal. Here spinal is kappa 1, supraspinal is kappa 3. Then respiratory depression is always mu2 receptors. Again, same thing. Sedation, euphoria. Here with kappa receptors, you can see dysphoria. It is not, yeah, here it is mentioned. Dysphoria. And another peculiar feature with kappa receptor is psychotomimetic features and then dependence, that is physical dependence. Then meiosis, then reduced GI motility in all the cases and physical dependence, morphine type here. And here it is affective behavior and then reinforcing actions with delta receptors. So same thing here, nothing much different. Yeah, agonists, endorphins, dynorphins, enkephalins. We discussed about. Apart from that, antagonists, naloxone, naltrexone, nalmethane for all the groups. And here you can see bradycardia, hypothermia, urinary retention. And with mu2, most commonly marked, that is constipation. So this is minimal with delta receptors. Then, so we discussed about mu, delta, and kappa receptors. Now it is nociceptin. So we have nociceptin. So we should have nociceptin opioid receptor also. So nociceptin opioid receptor combines with nociceptin, producing its own actions. So despite its structural similarity with opioid receptors, opioids do not bind to nociceptin receptor with high affinity. So endogenous peptide nociceptin or orphanin FQ binds with nociceptin receptor. So this produces nociceptin. When combines with nociceptin opioid receptors, it produces biphasic hyperalgesic and analgesic response, and it is also involved in the opioid reward and reinforced mechanism. Then another opioid peptide, that is nocistatin, is also derived from the same gene that we have discussed already. But this nocistatin is having the opposite effects like the when compared to the nociceptin. So it is blocking the effects of nociceptin through unknown mechanisms. So this is the central mediated analgesia through mu receptors, kappa receptors, delta receptors, and nociceptin receptors, but it is biphasic hyperalgesia and analgesia. Then peripheral analgesia. So opioids also produce analgesia through peripherally mediated pathways. So what is it? Peripheral opioid receptors. So they are not only present in the brain, so peripherally also they are present. They mediate analgesic effects when activated by locally applied opioid antagonists. So here locally applied means in case of knee getting affected with arthritis, so we go for intra-articular injections or even local application of ointments of opioid derivatives. So here the opioid receptors, mainly mu, are present on peripheral sensory nerves and are upregulated due to the process of inflammation. So opioid receptors that are present in the peripheral sensory nerves that are upregulated, and these endogenous ligands, the opioid peptides, are expressed in the immune cells present within the peripheral inflammatory tissues. So they will go and combine with the peripheral opioid receptors, mainly mu receptors, and thus produce analgesia. So they are secreted from endogenous opioid peptides. They're secreted from immunocytes, occupy opioid receptors and sensory nerves and produce analgesia by inhibiting the excitability of these nerves or producing or release of excitatory pro-inflammatory neuropeptides and pain producing, most commonly substance P. So the peripheral administration of opioids is what we just now discussed. So intra-articular injection or topical application, whatever it may be. So endogenous opioid peptides are released as soon as the pain is there, because the overexpression of the peripheral opioid receptors that are present in the sensory fibers. Okay. So this is the nociceptor that is getting in connection to the inflammatory cells. So overexpression of opioid receptors. Then we have, it is not sigma, it is sigma. So mu receptors, kappa receptors, delta receptors, we know. Sigma receptors, another classification is there, which is not classified right now under the subcategory of opioid receptors. Previously it was. So it produces hallucination, dysphoria, seizures, etc. So it is no longer considered because it is neither activated by morphine nor blocked by antagonists, that is naloxone. But certain opioids, that is pentagocine and butorphanol, they bind to the sigma receptors. They produce dysphoria, psychotomimetic actions, tachycardia, mydriasis, all this mediated by sigma receptors. Then, so we have like mu, delta, kappa, and nociceptive. So how these opioid receptor transducer mechanisms result producing analgesic effects. So opioid receptors, including nociceptive, they're all G protein coupled receptors located mostly on prejunctional neurons. But we do have like actions at prejunctional neurons and postjunctional also. So at the level of prejunctional neurons, what happens when these opioid receptors are expressed? So there is, after stimulation of the opioid receptors, there is inhibition of adenylyl cyclase, giving rise to decrease in cyclic KMP. So which is further important for cell excitability. So cell excitability goes down. And this happens through mu and delta receptors. So don't get confused where mu is coming, where delta is coming, where kappa is coming. So these are all very important points of VIVA-OC. And then inhibition of calcium conductance by suppressing voltage-gated N-type calcium channels through kappa receptors. Calcium kappa, similar sound, ka. Okay, so N-type voltage-gated N-type calcium channels inhibition through kappa receptors, and ATP synthesis decrease through mu and delta receptors. So reduced availability of intracellular calcium. So obviously the neurotransmitter release will be inhibited, like substance P and glutamate from nociceptive terminals. And then release of acetylcholine, noradrenaline, dopamine, 5-hydroxytryptamine is also inhibited due to activation of all three opioid receptors. So this is what happens at the level of prejunctional neurons. So what happens here? One is cyclic MP synthesis inhibition and calcium influx is decreased. Then here at postjunctional neurons, there are also like activation of these receptors results in potassium channel opening, giving rise to hyperpolarization of neurons and thus neuronal inhibition. There cyclic AMP and calcium channels are getting involved. Here potassium channels are getting involved. Apart from that, there is another system, that is MAP kinases and phospholipase C involvement, which are acting as like second messengers, leading to the formation of IP3 and DAG. Thus, the neuronal hyperpolarization coupled with decreased neurotransmitter release, so like hampers the transmission of the nociceptive information at the first central synapse. So nociceptive means painful. Painful stimulus is not getting transmitted. So inhibition of the neurotransmitters and inhibition of the signal transmission happens. So you can see here, opioid receptors, GPCR inhibits adenylyl cyclase, potassium channel opening, increased potassium conductance, reduced neuronal excitability, hyperpolarization, and relieves pain. Potassium channels opening, hyperpolarization through mu and delta, and through kappa receptors, calcium channel entry is reduced. So because of which decreased release of neurotransmitter. So GI, inhibitory in nature. Potassium channel opening, so this is positive. Then voltage dependent N-type calcium channel inhibition. Okay. Then adenylyl cyclase inhibition, cyclic AMP synthesis is inhibited. Then another extra action, MAP cascade, that is like phospholipase A2 cascade is stimulated, production of prostaglandins and leukotrienes. This is very rare phenomenon. So here you can see presynaptic and postsynaptic. Here cyclic AMP synthesis is inhibited. Apart from that, calcium influx is inhibited, neurotransmitter release is inhibited, Postsynaptic, potassium conductance is free. So free potassium ions flow, giving rise to hyperpolarization. So that gives rise to inhibition. Then coming to the pharmacodynamics. Central analgesia. Let us see. So I'm just depicting here the subtypes of receptors that are involved to that particular pharmacodynamic action. Okay. Morphine increases pain threshold. Sites of opioid analgesia include periphery as well as central. Central, that is spinal and supraspinal, which includes spinal is mu2 and supraspinal is mu1. Don't get confused with that of the kappa receptors. Okay. Activation of both mu and kappa receptors mediate supraspinal and spinal analgesia. Opioid analgesics reduce both sensory as well as affective component of the pain. That's what we discussed twice, I think, in our discussion today. So because of which the patient feels a sense of comfort, not only the reduction in pain. So here, central analgesia, mu1, mu2. Mu1 is supraspinal analgesia. Mu2 is spinal analgesia. Apart from that, kappa receptors are also getting involved. And affective component is also getting involved. Then how the analgesia is produced? By raising the pain threshold. Apart from that, sense of well-being, that is the patient is feeling and experiencing of euphoric state, because of which these compounds are most often used as drugs of abuse. Okay. Then they are most effective against dull continuous pain such as deep-seated visceral pain than a sharp intermittent integumentary pain. You should know which type of pain, which type of analgesics you have to pick up for the patient. Whereas neuropathic pain, like that of in case of trigeminal neuralgia, is less responsive to opioids. And then elimination half-life is increasing with age, so you don't need to go for higher dose there in case of old people. Opioid-induced hyperalgesia. This is what we discussed just a few slides ago. So opioids are producing analgesia, and they do produce like a biphasic response, hyperalgesia and analgesia also. So apart from the tolerance that these molecules produce, so when you administer opioid kind of drugs for a long period of time for managing, like for example, like chronic cancer pain, they increase the sensation of pain, resulting in hyperalgesia also. So selecting opioid kind of drugs in chronic diseases, like for example, most common, that is chronic cancer pain therapy, is still a big question mark because they also induce hyperalgesia. So this is most commonly seen with morphine, fentanyl, and remifentanil. So what is the reason behind this? So we know how the analgesia is produced, but hyperalgesia, what is the reason behind it? Spinal dynorphin and activation of the bradykinin and NMDA receptors mediate opioid-induced hyperalgesia. So opposite to that. So postsynaptic inhibitory action, that is what opioid receptor-induced net result that we discussed. So here NMDA receptors are getting excited, so producing obviously hyperalgesia. Okay. Then peripheral analgesia. So we discussed about central analgesia, mu1 and mu2, that is supraspinal and spinal, and kappa receptor involvement and affective domain involvement by raising the pain threshold, and then hyperalgesia, then peripheral analgesia, how it is produced. So what happens, we discussed this point already. During inflammation, peripheral opioid receptors are upregulated, overexpression of the peripheral receptors. So endogenous opioid peptides contained in monocytic cells or lymphocytes, which are there, they are attracted to the areas of inflammation, and then they combine with that. And then these endogenous opioid peptides, they act there at the sites of inflammation and then combat the pain, which is arising out of tissue injury. So exogenously administered opioid agonist directly to the site of inflammation, that is like intra-articular injection, that's what we discussed, can provide an effective peripheral analgesia because of this expression of the receptors at peripheral level. Then analgesia is over. Then next point is euphoria. So this is through mu1 subtype of receptors, along with sedation, hypnosis, and convulsions. So emotional well-being, that is euphoria, is due to mu1 receptors. So because of which the patient will be getting eliminated of normal fear, panic, withdrawal, flight response, all these things. So most common of drug of abuse. But sometimes dysphoria also can be experienced. So there's like difficulty, opposite to that of euphoria. Restlessness and malaise also can be present. So that is mainly because of kappa receptors. Euphoria is through mu1 receptors and dysphoria is through kappa receptors. And it also, this group of drugs also produce sedation. So how this sedation will be? The patient will be drowsy. So he can't concentrate on anything. So mental apathy will be there. So logic will be lost. And then extravagant, producing vivid and colorful daydreams. So not able to like a profound sleep. We can't say like it is like a profound sleep. So larger doses, but they induce sleep. So normal non-REM and REM cycle is disrupted. So that is kind of sedation that these patients experience. And when given at high doses, they induce supraspinal stimulation, giving rise to convulsions. Then respiratory depression. Euphoria is with mu1 and respiratory depression is with mu2. And central analgesia is with both mu1 and mu2. Okay. So this respiratory depression is directly proportional to the analgesic effect. So the more profound analgesia the patient is experiencing, the more profound respiratory depression will be there. So you can't avoid, you can't take one thing and avoid the other thing. Apart from that, bronchoconstriction because of the histamine releasing action that is produced by morphine. So as a result of, and interference to breathing as a result of psychological action of morphine. So they all added together can give rise to the respiratory difficulties to the patient. Then, so with the toxic doses, further higher doses, hypoxic drive, that is like breathing is mainly maintained by the hypoxic drive through the carotid and aortic body receptors, and which can give rise to the Cheyne-Stokes respiration. If you take in the graph, that will be depicted there. So when this hypoxic drive is maintaining because of the excessive carbon dioxide input concentration, so you can't eliminate this hypoxic drive, making the patient land upon in the respiratory failure. So for that reason, because thinking that the patient is in hypoxia, then I have to administer 100% oxygen. No. This hypoxic drive has to be maintained at certain level so that the patient will not land upon a respiratory failure. So for that reason, you should not go for 100% oxygen administration, but moderate concentration of oxygen and controlled assisted ventilation. Then respiratory depression is seen, which is like a profound, dreadful adverse effect that is seen with most commonly with opioid derivatives, which is the most common cause of death in acute opioid poisoning. But of course, tolerance to this respiratory depression is seen over a period of time. Then cough suppression because of direct depression of the cough center. Then most commonly codeine and dextromethorphan and noscapine are used as cough suppressants, which are used for non-respiratory, which are used for like non-infective cases, like non-respiratory depressant opioids, that is like dextromethorphan and noscapine. Okay. Then, but this cough suppressant property is not directly related to analgesic and respiratory depressant property. Then suppression of, same point. But apart from the cough suppression that the opioids produce, there is also a possibility of accumulation of secretions because of cough suppression. So, and because of the histamine release, again, bronchospasm will be there. So accumulation of secretions, cough suppression. So all these will land upon it, make the patient land upon it, airway obstruction and atelectasis. And then Again, for cough suppression also, there is tolerance phenomenon seen over a period of time. So it goes down, tolerance means. Then meiosis. Mu, it is because of mu and kappa receptors. It is due to morphine, that is centrally mediated effect caused by mu and kappa receptors because of the stimulation of third cranial nerve nucleus, that is Edinger-Westphal nucleus, that is parasympathetic in origin. So this meiosis, which is parasympathetic in origin, can be abolished by parasympatholytic drugs, that is by using atropine. So it is direct action on third cranial nerve nucleus, but not on circular or radial muscles of iris, so which we can see in the eye. So when you instill morphine or any opioid derivatives directly, instill the drops into the eye, they are not going to produce any effect because there is no direct action on circular or radial muscles of the iris. So this is the most common point that is asked in Viva. But respiratory depression, all these things, analgesia, euphoria, all these things over a period of time, they produce they experience the tolerance phenomenon, but the meiosis does not produce tolerance, this meiotic effect. So poisoning cases, chronic administration cases also, and even like not poisoning, I can say morphine addict patients, they do experience meiosis still because it is not going to experience this meiosis effect is not going to experience the tolerance phenomenon. Okay. Then truncal rigidity, increased tone in large trunk muscles due to spinal and supraspinal action. So this reduces thoracic compliance. The patient may not be able to inhale. So the ventilatory, the reserve will be affected. Then the effect is more apparent when high doses of the highly lipid soluble opioids, that is fentanyl, sulfentanyl, alfentanyl, remifentanil, are administered rapid IV. Then this truncal rigidity may be overcome by administration of opioid antagonists. But the moment you administer antagonists, the analgesic effect is lost. So how to maintain this analgesic effect? Again, to abolish the truncal rigidity, the only option that is left over is by using neuromuscular blockers. The nausea and vomiting, because of the direct stimulation of the chemoreceptor trigger zone. But in poisoning, over a period of time, they depress the vomiting center also. Initially, it is stimulation, so the patient will complain of vomiting. But later, emetic center is depressed. So, MSS has a general principles in the management of poisoning in case of opioid poisoning is not applicable when a patient is brought late to you because the vomiting center is suppressed. Okay. So, in case of morphine poisoning, vomiting is absent and emetics are ineffective. Then apart from that, vestibular component to nausea is also seen. So when the patient is in an ambulatory position, so more of vomiting. And this can be treated by using nalorphine, prochlorperazine, metoclopramide, haloperidol, but not by antihistaminics. Then temperature. Homeostatic regulation of body temperature is mediated in part by the action of endogenous opioid peptides. So mu opioid receptor agonists produce hyperthermia and kappa agonists produce hypothermia. Sleep architecture, decrease in the stage 3 and stage 4 sleep and sometimes central sleep apnea also may result. Then direct depression of medullary vasomotor center giving rise to hypotension. And most commonly bradycardia due to stimulation of vagal nucleus. And spinal cord stimulation giving rise to convergence. This is usually masked by the depression of the higher centers in the CNS. Okay. And apart from that, CSF intracerebral pressure also may be raised up. That is why we don't use, morphine is absolutely contraindicated in head injuries. We'll discuss about it in the second session. Then cardiovascular system. So usually bradycardia, but meperidine produces tachycardia through antimuscarinic action. Then blood pressure is usually maintained and sometimes hypotension because of the vasodilatation, peripheral arterial and venous dilatation. Then cardiac output is not changed and ECG is also not affected. Then GIT, mu2. So you need to recapitulate again and again, revise it. So mu1, mu2, kappa 1, kappa 2, and delta receptors, all these subtypes, which system is getting involved. GIT, mu2 mainly. So it induces spasm of the smooth muscles of the gut, the ileocolic and the anal sphincters, reduces the propulsive peristaltic movements. So spasm of the smooth muscles, mu2 receptor, GIT. Spasmogenic action is most prominent in duodenum and large intestine. And reduction, apart from the spasm, reduced peristalsis, reduction in the saliva, gastric acid, and intestinal secretions. Then desiccation of the fecus because of the reduced secretions, no peristaltic movements, and spasm of the sphincters is there, including anal sphincter. And apart from that, inattention to normal sensory stimuli from the loaded rectum. So all these factors put together will make the patient get landed upon in the stage of constipation. But this pharmacodynamic property is used in the management of treating certain cases of severe non-infective diarrhea. So these opioid derivatives are used in that condition. And again, like that of the meiosis, this constipation also does not experience the phase of tolerance. So there is no tolerance to meiosis and GIT effects, that is constipation. Then, of course, spasmogenic action of morphine there. That is, smooth muscle spasm can be relieved by administration of atropine, which is a smooth muscle relaxant. So in that cases, like in case of constipation, high fiber diet or senna or lubiprostone are prescribed. So apart from the spasm of the smooth muscles of the intestine, spasm of the anal sphincter is also there, resulting in erection of the tail in case of mice. So that is otherwise known as Stroop's test. The tail will be, when you inject a morphine, we used to do while I was doing MD pharmacology. So I have done that experiment also by taking a mice and injecting pentagocine. Morphine is not easily available to you. It is not OTC. So pentagocine, so injected at the base of the tail, then the morphine, no, not a base of the tail, intraperitoneal injection. Then over a period of time, the spasm will be there. The sphincter, anal sphincter there will be spasm. And then there will be erection of the tail, that is known as Stroop's test. So you can see that here. So phenomenon of Stroop's test, anal sphincter spasm. So you can see here, this is mainly used to identify the poisoning in biological fluids. Reconfirmation with animal tests for postgraduate students. Very, very important. Then action on biliary tract. So spasm of the sphincter of Oddi. So because of which biliary colic will be there. And if it is there, it will be like underlying disease is exacerbated. So same again, atropine combats the biliary spasm. And the sphincter of Oddi constricts. Apart from that, it results in reflux of biliary and pancreatic secretions and elevated plasma amylase and lipase levels. So it should be contraindicated in pancreatitis also. Then urinary bladder. Constriction of the urinary sphincter, difficulty in urination or urinary retention, contraction of the diaphragm muscle, urgency to urinate. Then renal. Renal function is depressed by opioids due to decreased renal plasma flow. And then predominantly antidiuretic effect is seen with sodium tubular reabsorption. Then increased sphincter tone, ureteral and bladder tone, and ureteral colic. All this can be seen because of the smooth muscle spasm. Then other smooth muscles, bronchoconstriction, most probably because of histamine release. But regarding the uterus, increased uterine tone. So that can be useful for the prolongation of the labor, but it is not therapeutical use for that purpose. It has the tendency. It may increase the neonatal morbidity due to bronchoconstriction and fetal respiratory depression. So it is not usually advisable to administer opioids in pregnant ladies. Then endocrine. Opioids stimulate the release of antidiuretic hormone, prolactin, somatotropin, but inhibit the release of luteinizing hormone. Low testosterone, giving rise to decreased libido, energy, and mood. And in case of women, dysmenorrhea or amenorrhea. Then pruritus. Again, it is central plus peripheral effect. So producing flushing and warmth of the skin, sweating, urticaria, and itching. Peripherally, it is due to histamine release, and centrally, it is due to pruritoceptive neural circuits. So both central and peripheral action. Immunomodulation. So lymphocyte proliferation, antibody production, angiogenesis, chemotaxis, all this will have a modulatory effect. So we have already discussed in the peripheral pathway, leukocytes migrate to sites of injury or inflammation, and their endogenous opioid peptides act. Then long-term use of opioids depress the immune system, that is T helper and suppressor cells, leading to increased susceptibility to infection. Thank you. So this is all about the first session of opioid analgesics and antagonists. And in the second session, we'll discuss about the pharmacokinetics and then toxicity and then therapeutic uses, drug interactions, precautions, and contraindications. And this chapter is very, very, very important for you, for your clinical aspects when you go to the postings. And then for your, when you become doctors, it is going to be very useful throughout your life. So please pay attention. Don't think that you can read from your textbooks. So it is like simplify. Teachers always simplify. So don't just depend on the textbooks, like even guidebooks. I have seen some of the students referring the guides. So don't use those things. Go through the classes and prepare well for the exam. Wish you all the best. Thank you. Thank you all.